keeping training physiological neutral when you were doing a cervical passive range motion too. Down with that. I'm going to get them slightly flexed. So I'm going to let you lay on your back. Okay. So anytime, and I'll come up around here. I want you to see this. I want you to understand this. You're going to try this with your partner. Okay. I can even see Tia laying here. I can see her SCM muscles. Look, when she lifts up, did you see that? Everybody come around here. Everybody come around here.
Wait. You volunteer.
I don't have any boogies in my nose too much.
What?
I don't have any boogies in my nose.
Oh, no.
Okay.
I don't see anything.
Okay, great.
Yeah, you're clear.
Okay.
All in the clear.
Thanks.
I didn't really investigate, but I think we're clear.
Okay.
Okay. All right, lift your head up again. What do you see right here? Boom, boom. What is that? SCM, right? Okay. So that is, remember, when it contracts unilaterally, here, here, but when it contracts bilaterally, here. So if I'm lifting my head, do you see how she's kind of getting that protraction versus flexion? Okay. So when I have somebody do a chin tuck, a lot of times I see that motion happen. Okay. The deep cervical flexors are in here. You can see Tia's SCM muscles. The deep cervical flexors sit medial to that. Okay, right along that trachea. Okay. So they're right in here. And so I will even give patients tactile cueing. I'll tell them I want you to, and I will guide them. I'll say, I'm gonna have you, do you mind to take your glasses off?
Yeah.
This is how I will typically teach patients. So relax into my hands. I'm gonna bring this here, get the pillow position so it's keeping her in a physiological neutral position. And I'll guide them. I'll say, okay, we're gonna tuck your chin just like this. So craniocervical flexion, right? Subcranial flexion. An OA forward nod, that's basically what this is. Okay, and I'll guide them a couple times and I'll say, okay, this is the motion. Now I want you to do that. You use your muscles right here to do that. Okay, and you're gonna see a little SCM fire, but it shouldn't be all SCM. And then if I get in here and I, go ahead, tuck down, I should feel, and I do, I feel Tia, now I feel it better. I feel her little deep cervical flexors activating, okay? Relax. And so I'll have a patient do this until I feel like they are adequately doing this without tensing up everything around it. Again, I'm not saying your SCM isn't going to be active at all, but you should be getting recruitment of those deep cervical flexors. They should be able to isolate that forward bend, okay, chin tuck, and not just be here, okay? There's a difference. So I will work through this and I will have them get there. Once they get there, this is what I like to do, okay? I will take them and I will have them tuck. I will place them into a little bit of flexion. Now in a flex position, I'm gonna have her tuck her chin. Tuck your chin there, Tia. Now hold it. I'm gonna have her hold it, and I'm gonna back off on how much I'm supporting her head. She is holding her head, my hand is still here, but I've backed on off, okay? Relax back into my hand, and then I'll bring them back down. And I'll let them do these isometric holds in a flex position where they're engaging, okay? I'm gonna relax. I'm gonna place you tuck, hold, okay? And I can feel them activating right here. And relax. Once I feel like they can do that, well, then this is what I like to do. Then I'll have you tuck. Now lift your head up and forward, keeping the tuck, keep the tuck. Come back down, keep the tuck, keep the tuck, keep the duck, and relax. Okay, so now I can tuck with the stabilizer, have her activate her larger global muscles to pull the head into flexion, and relax, okay? And that's how I will combat, along with, while I'm also doing, and I've probably done first, some soft tissue to the SCM, some soft tissue to the suboccipitals and those cervical extensors. But I want you guys to, I want you to go try that with your partner, okay? Go feel those neck flexors. Feel the difference between them flexing and just lifting up there. All right, so Spurley test. This is on page 377 of Olson. Can I have a volunteer for me seated up here in the chair, please? All right, so any neck issues? Okay. So Spurley. So we just talked about compressive stress. We talked about the neuroforamina. Man, this guy's vertebral artery has seen better days. Yeah. Okay. But the you all kind of understand how flexion is going to open up the neuroforamina. When we're talking at the cervical spine, if we're talking about the right side of the cervical spine, what motions are going to close down around the nerve and narrow extension, right rotation, okay, and also one other motion.
Right side bending.
Right side bending, so ipsilateral side bending, okay? So Sperling's test, there's 2 steps to this. We do step 1, and that is simply side bend to the right, okay? Or let each side, we're gonna do one side at a time. So ipsilateral side bending, right? So if I go to the right, and that reproduces my patient's radicular symptoms, their complaint of pain, numbness, tingling that's radiating down their arm, I probably don't have to do anymore. I can say that's a positive Sperling test A, okay? If that is clear, and that does not cause them problems, then as I side bend them, I can add some compression, okay? Straight down, so they're in a side bent position, straight down. Okay, I think it says about 7 kilograms, so 14, 15 pounds of pressure. Do you guys have one of the weights here? Have you guys ever played around with that to see how much pressure that is? I don't know if there's one laying around. I'll have to ask. Could be a good little exercise as well. But about 15 pounds of pressure. And so what is compression going to further do? Close the neuroforamina around the nerve, right? So if they're having nerve root impingement, chances are that has the potential to exacerbate that, okay? Now, if that is clear, we can move on to Sperling's test B. Sperling's test B starts with the side bending and then adds ipsilateral rotation and extension, backward bending, okay? If that provokes the symptoms, positive Sperling test B. If not, then we're gonna add compression in that position, okay? Checking the other side. If my patient, now I don't know that it says this in the book, but this is typically how I do it. If my patient has how do we know if that's normal for them? I mean, normal, it's really not normal to get symptoms. But we know with special tests, we compare side to side, right? So I usually do their uninvolved side first and then check their involved side. So if Seth came to me with right radicular symptoms, I would probably do his left side first, okay? And it would look something like this. Okay, we would do some side bending. Any issues there, Seth? Okay. And then from here, I'm gonna apply compression straight down, 14 to 15 pounds, probably about like so. And I'm gonna ease into it and I'm gonna ease out of it. Any issues there? Okay. I'm gonna come up and I'm gonna compare. So we're gonna side bend to the right. Any issue there? I'm gonna add compression straight down. Ease out. Any issue there? Okay. Come back. Then I can go side bending, ipsilateral rotation, and backward bending. You okay right there?
Yeah.
Okay. How about there?
Good.
Okay. Come back up. They also recommend doing this in front of a mirror. You may or may not be able to do that. Okay. But if you have one, it allows you to visualize their facial symptoms too. Are they grimacing? How are they tolerating and responding to this? What other position does this mimic that we could be compressing? Vertebral artery. Any issue there? Okay. So if I do this test and they're not complaining of a reproduction of symptoms into their arm, but they're telling me, man, my eye's doing something funny, or, oh, I feel lightheaded, or they are slow to respond to you, I might want to investigate that a little further. Okay. All right. So that is Sperling's test A. Sperling's test B. Any questions?
I have a question.
Yes.
When you're applying force, is it going diagonally or straight down?
Straight down.
Okay.
Okay. So if you can imagine, I'm getting him over here, and then
Going down. Okay.
like that. With the intention, I'm putting the force in a position that I feel like is going to compress, close down around that nerve on that side. Yes. Okay, so step 1 was put them in position. If they were okay with position, then I added a compressive force. Okay, in both A and B. A being just side bending or lateral flexion. B being side bending plus ipsilateral rotation plus extension or backward bending. Then compression. Okay. All right, next test is the shoulder abduction test. Okay, so with Sperling test, Sperling is a positive test. It's a provocation test. It's positive if we provoke or reproduce that patient's symptoms. Shoulder abduction test is looking for relief of symptoms. Okay, it's not trying to provoke symptoms. We are looking for relief of symptoms as a positive test. Okay, so essentially what we're going to do, have our patient seated, and we're going to ask them to put their hand, okay, on their head. So if he had right symptoms, he's coming in complaining of right symptoms, and he puts his arm, and he's having them actively, and I have him put his hand up here, and he tells me, that feels a little better. Then I'm thinking, okay, because what has he just done? Okay.
No, okay.
Okay. While he hasn't moved his head to open up the neuroforamina, he may have decreased that compressive stress around that area by putting some slack in the muscles attached to that. Can you see that? Right? Upper trap's another one. Where's your upper trap attached? From here up into here. So if it's tight, it does this. Right? So if I put that on slack and I get relief, okay, it may be that I've opened things up somewhere, whether it's cervical or even potentially even a thoracic outlet. It could move some things around to open up the area around the nerve. So if there is relief of symptoms, that's a positive test. That's essentially it for that one. All right, those first. Okay, so for this test, you go ahead and lay back. I'm gonna get my patient comfortable. I may prop them up on them. Let's just do it. Okay. Anybody in here ever heard the term concordant sign? Anybody know what that means? Besides Emery? No? Okay. So you're going to hear this term, and especially when grand rounds start. Upstream, they use this term a lot, okay? But you're going to see it in the literature a lot. So the concordant sign would be the sign, like the thing that brought them to you. They came to you because they've got this headache that starts here and comes up here, okay? And that's what they came to you for. That's the concordant sign. Okay, they came to you because they've got this pain that's radiating down into their fourth and fifth digit. That's their concordant sign. Okay, they came to you because every time they lift their arm up, they get this pinchy sensation here. That would be their concordant sign. Okay, so if you hear that term, know that that's what that's referring to. So these tests, like the Sperling's test, you're looking for a reproduction of their concordant sign. Whatever it was that brought them into you, that their complaint, okay? Now, if they came to you for knee pain, I don't know why you'd be doing the Sperling test to begin with, but it might not be their concordant sign, but you would make note of that, you know. Does that make sense? Because you're going to see that term, you're going to hear that term, know what they're talking about. Okay, thank you. All right. So, scoot back for me if you can too. Let's get your head toward the top of the table, but with these tests, all these tests, you still want head to be on the table, but toward the top of the table. And so for the neck distraction test, I'm going to come here with one hand, and I'm going to support the occiput. Okay, so I've got the occiput in my hand. Now the idea is distraction, right? So I'm going to pull the occiput away from the rest of the neck. Now, in the one technique that we learned as a treatment, we stabilized C2. So our distraction force was focused between the occiput and C2. So we really were only distracting the occiput from C1 and C1 from C2, and that's where the distraction stopped because we stopped it with our hand. Okay, for this test, we're not going to stop it with our hand at C2. So when I distract her, and I can do this two different ways. One, I can come right here. I'm going to try not to hurt her. And I wouldn't do it this way if that person had TMJ complaints, okay, dysfunction there of their TMJ. I wouldn't probably choose this method, but as long as the person doesn't have any jaw issues and they're tolerant to it, and I make sure that their mouth is closed, that they don't like bite their tongue, right? But I'm getting here, and I'm applying the pull with my arm on the occiput. This is just helping me maintain the head in the position and getting a little bit of extra pull. Again, about 14 to 15 pounds of pressure. Does this change your symptoms at all, Tia? Okay. If Tia said, oh, that feels so good, that actually makes my arm feel better. Or I don't feel it as much in my hand, I still feel it in my shoulder, but I don't feel as much in my hand or my forearm, then that is an alleviation of her symptom, and that would be a positive neck distraction test. Okay? Now, if I don't want to pull through her chin, I can do the same thing by putting my hand here on the forehead. So again, it's just giving me a little bit more help to apply this distraction force. But this distraction is going to start at the occiput. I'm going to distract through C1, C2. She may even feel this into her upper thoracic spine. Probably not strong enough, pulling hard enough for her to feel it into her lumbar spine, but she may feel it into her thoracic spine, okay? But it's gonna distract the whole thing. So if you had somebody who had an instability, maybe in their C5, C6, you may not want to do this, okay? If somebody's had you wouldn't do it, or you wouldn't do it that hard, or you would do it in block, right? But we wouldn't be doing this test if somebody just had a cervical fusion. We probably aren't doing this test, okay? But just keep that in mind. So that is the neck distraction test. Any questions about that one? Okay, go ahead and sit up for me, Tia, back in the chair. I'll have you keep your glasses off still if you don't mind. The next is the neck traction test. So this is a test in a seated position. Now we are going to create the distraction force via the mastoids. Okay, so I can come up behind her like so. Okay, it also suggests doing this in front of the mirror. Be wise with your patients. I think T is okay, but if they have earrings in and I feel like there's a chance I'm gonna get it at all, I'm gonna have them take it out, okay? But I'm gonna come here, and with this part of my hand, okay, I'm gonna come up here and I'm going to find her mastoid, and I'm gonna get up here where I can get her mastoid, and maybe really right in here on that side of the MCP of my second digit, my index finger, and I'm gonna come straight up, like I'm trying to lift her head up off her table. Okay, what do you feel?
That was painful.
Okay, is it painful from the squeeze in my hand?
No, it was like painful when you lift it up.
Okay, where did you feel it?
Like on the mastoids.
On the mastoids. Okay, I'm gonna try to change my position a little bit. I'm gonna try to get more my meaty thenar eminence. See if I can do it again, because what she is telling me is not radicular symptom. It's probably discomfort from where my hand is. That's what I took that as. But I'm gonna read. So I'm gonna modify, and we're gonna check again. All right, easing in, sink through the soft tissue. How about that?
That's good.
Okay. Does that change any symptom at all?
No, well, it's not painful like it was before. This is fine.
Okay. So again, what we are looking for is alleviation of symptom. I suspect the first time I did it that I probably had a little bit of pressure also on her mandible, and it didn't feel so good. Okay, there I felt like I could cut with the meaty part of my hand on her mastoid, and I was able to accomplish the traction force more effectively. Right? So both of those tests are a test for alleviation of symptoms as a positive test. So go ahead and try those two. Okay, so for the upper trap muscle length test and stretch, okay, we're going to start with our patient supine. I like to get them, again, relaxed. Okay, put them on a pillow, try to get them in physiological neutral, which is slight flexion, maybe 20 degrees of flexion, okay? And so from this position, if I were going to, do you mind taking your jacket off for me?
Yeah, absolutely.
That way they can see your shoulder blades a little bit more. So we got to think about where our muscle attaches. Whatever muscle we're stretching, we are trying to separate the origin from the insertion, or vice versa. Okay, we want to separate those 2 points. So for the upper trap, I'm going to move his head while I'm stabilizing here the scapula. Okay, so I'm going to get here where I can with one hand. So if I'm going to stretch the left side, I'm going to get my hand here to stabilize the spine of the scapula, maybe the first rib a little bit. Okay, and just all the bony structure right here. My thumb may even come across to the clavicle, but really the spine of the scapula is the key here. Then I'm going to take his head into contralateral lateral flexion, side bending. So I'm side bending away. May even rotate toward just a touch. Okay, so a slight ipsilateral rotation, and I'm going to hold it. Okay. So I'm feeling that length. I'm going to compare. So the muscle length test is feel that and compare that to the opposite side. So I come here on the right side now, stabilize the spine of the scap. Okay, first rib area, and I'm going to compare. I might get resistance a little faster right here, okay, but they're fairly symmetrical, right? So I can make this a treatment, and I can just do a static hold. I'm gonna take him to that barrier, And now I can say, Jordan, all right, I want you to hold your head right here. Don't let me move you, okay? Don't let me move your head. Hold it, hold, 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 and relax. And as he relaxes, I take up the slack. So I can do like maybe your book suggests a 10-second isometric hold. Do that again, okay? So resist me, don't let me move you. Hold it right there, hold right there. Hold, 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 and relax. And as he relaxes, I'm engaging the new barrier. Let's do one more, okay? Match my force. Hold, hold, hold. It's submaximal. Hold, and relax, okay? And then I'm gonna ease out, okay? Then I may check that. Now again, in the clinic, before I do that, I've probably even come in here and done a little bit of gentle myofascial. I may do some ischemic pressure. I may do just some myofascial release techniques. I may come in here and do some trigger point release if I feel any trigger points in here. And then I'm probably going to go in here and do these stretch techniques manually. And then I'm going to follow that up by giving my patient some kind of self-stretch, okay? And then we may do some, what would be maybe a supporting intervention that you could do to follow up a passive stretch followed by a self-stretch. What else could we do strengthening wise that might be appropriate? What's that? Shrugs. And sometimes I will have my patient do shrugs with the emphasis on relaxing them all the way down, okay? A lot of people, I find that people tend to be more on the overactive side with the upper trap than they are weak, okay? They tend to be more tight than weak. So sometimes I will give my patient shrugs simply so that they have to figure out how to fully relax them and elongate, okay? That's another one that is very dominant when we're talking about shoulder. Somebody, if somebody can't use their rotator cuff effectively or they're having some impingement but they're trying to get up, what do? This, right? You see a lot of that. So those patients, I don't give them shrugs to just concentrically make them a lot stronger, but sometimes I will give it just to emphasize the elongation and relaxation of it, okay? But again, that's a muscle that increases compressive stress to the cervical spine, so it's one that often needs to be addressed. Okay, levator scap, all right? So levator scap, we're also gonna do supine. We've got to think about where it attaches. Where does it attach on the scapula? Y'all remember where it attaches on the scapula? Okay. Superior medial border. So if we wanted to stretch Jordan's left levator scap, we can take that arm, that side arm, the ipsilateral arm, and we can bring it up. What am I doing to the scapula here? What am I doing? Upwardly rotating it. When I upwardly rotate it, what happens to that point where the levator scapula attaches? Right? If it upwardly rotates and it's attaching right here, while the scapula is upwardly rotating, that point where the levator scap attaches is moving inferior, right? With upward rotation, can you envision that? So again, the goal is separate origin from insertion. So I'm gonna put his arm there to give me a little bit of help of separating those 2 points. And now I can still come down and stabilize the spine of the scap in that same area I did for the upper trap. Get him into a little bit of flexion. And now I can do contralateral side bending and contralateral rotation. Okay, not losing the little bit of flexion. I don't want him here to be extended, okay? I want him to have a little bit of flexion. And I can feel that tensing up around my ham. And again, I can hold. Okay, I'll do one isometric contraction here, okay? So Jordan, I'm gonna find that barrier. Okay, resist me, don't let me move your head. Hold, hold, and relax. And as he relaxes, I engage that border a little bit more, or that barrier, okay? okay? I could do that again about 3 times. The courtesy rub down, okay? It's a length test first, so I'm going to compare side to side. So this is what it looks like on the other side. So I'm going to take his ipsilateral arm, bring it up into full elevation, okay, full flexion. I'm going to shift the pillow over a little bit because I want him to be able to relax. So I don't want him to feel like his arm. If he's trying to hold his arm, he's afraid it's going to fall off, probably not going to be as effective at checking this. Okay, so I've got him physiological neutral, slight flexion. Coming here, stabilizing with my same side hand, with the other hand. Okay, I'm going into contralateral, lateral flexion or side bending, contralateral rotation while I'm maintaining that little bit of flexion. And I can hold isometric contractions. Any questions about that? Okay. The flexion, the cervical craniovertebral flexion is key. Side bend away, rotate toward. Okay, it's similar to what we just did, except we don't have the arm up like this. Why don't we have the arm up like that? Where's the SCM inserted? Where are the attachments of the SCM? Sternum, clido, clavicle, okay? And then the mastoid, right? And occiput. Lateral part of the occiput. Okay. I'm gonna go in reverse order too. I'm gonna start with the suboccipital release, inhibitive distraction, because again, that is probably where I'm gonna start when I'm treating my patients. I think it makes sense to start with that one, and then we'll go back to the talk about this. So. So what are our suboccipital muscles? What kind of muscles are we talking about when we're talking about suboccipital muscles?
Capitis, rectus capitis,
Rectus capitis, posterior, what? Minor and major, right? We've got those are back in that area. What are the other ones we have up there? Superior and inferior, right? So we've got this suboccipital group. Can I get a volunteer? This one actually feels really good. This is like probably my favorite technique of all that we're doing. All right, then you'll like this one probably. Okay, patient relax. It's key. This is a relaxation technique. Okay? This is a technique that I will, do you mind just slide your glasses off and just put them on your belly? This is a technique I use very often, okay? But it's kind of my go-to. 1, to relax the muscles, but 2, to just gain trust with my patient. Okay, so before I get in there and I'm doing a lot of gliding and stuff, a lot of times I will spend a little bit of time here just for a couple reasons, especially if it's the first session or it's the first time I've seen that patient. If you think about it, let's say you've been in an accident, you've had some whiplash, you don't know this person, you've never had therapy before, you're not exactly sure what they're gonna do, all you can visualize is a chiropractor like popping, snapping your neck, you're not sure what the PT is gonna do. It's kind of a hard situation to relax in, especially if you're in pain. Okay, so I have found that this is a great technique to just allow my patient to gain trust in me, and it also lets me gain a little insight into how tight they are, how well they relax, how guarded they are in certain areas. So it's a good technique to just hang out. Okay, so I will start with my hands just holding her occiput. You can see my fingers aren't even here. I'll just hold her head in my hands. Once I feel like, okay, she's letting go, she's not trying to resist and hold her head. Some people just want to help you, and they will hold their head because they feel like their head's going to squash your hands and they don't want to hurt your hands. Okay, so just let go of it, right? She's letting go, but sometimes I have to start here till my patients let go. Then I will move to where my fingertips, okay, 2 through 5 digits, those fingertips are going to come up just below the occiput, where those suboccipital muscles insert into the occiput. And I'll use the pad of my fingers, and I'll let her just get used to the feel of that. And once I feel like she's totally let go there, then my hand starts to go from here to here. Okay, maybe not total kickstand, but you'll hear that, kickstand. Okay, but at least here to where my fingertips are now supporting the head. There's not much weight on the palm of my hand. Most of it is on my fingertips. Okay, so it's compressed, it's inhibitive pressure to the suboccipital muscles. Now, your patient with suboccipital headaches, what do they usually present like? Do you know? Do I know yet what a suboccipital headache will typically present like? The pattern of pain? Somebody comes to you and they're talking about how they get this pain in the back of their head, and it just feels like it just radiates from here, it comes up, travels to their forehead, and it's just really aggravating. I suspect suboccipital involvement. Okay, what nerve runs through those suboccipital nerves? You know what nerve is there?
It's a branch of C2. Wait, hold on. It's in my notes. So sad. I know it's like occipital something.
Yeah, that's good. It's a good start. Okay. How about the greater occipital nerve? Okay, the greater occipital nerve travels through this suboccipital triangle. So if the muscles are taut, just like we talked about sciatic nerve being compressed by piriformis, up here we often see that when the suboccipital muscles are taut, that they can compress the greater occipital nerve, and we can see occipital neuralgia. Okay, so it's a great technique for those patients, but it's also a really good technique for just about any of your neck patients. If nothing else, just to get them to relax and develop that trust with them. Now, to get them to fully relax, you might have to spend 5 minutes here to get full relaxation of the muscles. So I usually hang out here until I feel like they have totally let go of their head. For some people, that might be 30 seconds to a minute. For some people, that's closer to 5. Okay. Once they're relaxed, okay, then I can do a couple different things. If I'm doing a true technique like it's described in your book, which is a suboccipital release and inhibitive distraction, then what I do is I transition my fingertips from pushing up on the suboccipital muscles to now grasping the occiput, and now I can pull. So now I've gone from inhibitive pressure on the suboccipitals to distraction force through the occiput. Okay, it may not be quite as strong as it is when I get my web space there and I grab her chin or her forehead or put my shoulder against her and pull, but I can create some distraction force here as well. Okay, so that's the suboccipital release technique. If I'm going to be working on their SCM or their upper trap, again, I'll start with that, and then I'll say, okay, don't lift your head, stay relaxed, and I'll transition my hands here, and I'll go into whatever soft tissue techniques that I want to do, follow that with the stretching, then go in and start doing my other techniques. Okay, everybody good with that? Okay, it's a great technique. Learn it, use it. All right. Then that takes us back to mobility testing. Yep. That. So we're back to the cervical down glide. PIVMT, what's that stand for? Okay.
Passive intervertebral motion test.
Excellent. Yes, passive intervertebral motion testing. So you'll see the first technique here, cervical down glide, down slope, passive intervertebral motion test. Page 396, 397. Then if we come down here a little bit further, we see cervical spine VG, which is down glide, manipulation, page 403, 404. Essentially the same technique. The assessment, figuring out where they're restricted, and then once we figure out where they're restricted, we can turn that glide for assessment into a manipulation to mobilize and to treat. Okay? So we'll kind of do those together. So let's go ahead and we'll go to page 396 to 97. Now, this is a little bit of a review from what Dr. Carter had in the other slide. They may be described slightly different, but it's pretty similar. So the set downslide technique that I think we did last week, it's real similar to this technique right here. 396, 397. Okay, the intent for this is the same intention. Okay. I'm going to bring the table up a little bit. I'm going to use the pillow like for the down glide. I'm going to use the pillow like my third hand against my abdomen. C7 is gonna be my third hand. So I'm gonna get her here where when I'm in an athletic stance, I can have her right against my belly. Okay, again, Dr. Carter likes to start low. He likes to start C6, C7 and work his way up. I prefer to start high, C2, work my way down. You can do either, just do what makes most sense to you, just be systematic. I wouldn't check C3, C4 and then come back and check C6, C7 and then go back to C2, C3. You'll get all confused in your mind. So either start at the top and work down or start at the bottom and work up. Okay? I'll tell you what, Liz, come back toward me another inch or two. Good. Let's pull this up. So she's relaxed. Again, watch your patient's earrings. Make sure you don't feel like you're gonna get their earrings. So look, I've got her controlled with my stomach, okay? Now my hands can find position. So I will find the occiput, find C2 spinous process, and then I'm right hand dominant. I usually try the right side first, it doesn't really matter. But C2, then I'm gonna drop off with this part of my hand onto the articular pillar of C2 so that I can assess the downcline of C2 on C3. So my direction, my line of force is going to be essentially like this. I'm envisioning that facet plane in my head. It's about a 45-degree angle, and I'm going like this. I'm taking her to end range, C2, C3. So I looked at right C2, C3 down glide, then I look at left C2, C3 down glide. Then I work down just a level, it's just a tiny little bit. I should be approximately C3, C4, C3, C4, okay? C4, C5, it gets a little tighter. C5, C6, C5, C6, C6, C7, C6, C7, okay, and I might could get down to C7, T1, okay, but primarily C3 to, or C2, C3 to C7 is usually where we're working with this, okay, so that's the down glide. So for Liz, I felt like she was slightly more restricted. It was very slight, but about C4, C5, down glide on the right, I felt a difference right to left. So I'm gonna treat that level, okay? So I can get her back in this position. This I think is page, what did it say, 403, 404, whatever that ladder technique is the manipulation. It's the same setup. So here I find C2, C3, C4, spinous processes. I'm going to get my hand on the right side, the mobilizing side. I'm going to get it in line, or right on that articular pillar. Okay, there's the down glide, so that's it right there. Now, to treat it, I can just get here, and maybe I can get her right here. My forearm is in line. I can even shift this way a little bit if I want. And now my left hand, instead of being ready to check the other side, now it's supporting the head so that I can be more specific and focused to manipulate. Okay, so I can do a grade 1, okay, or a grade 2 oscillation, grade 3 oscillation, go to end range and do a grade 4. If I feel like I don't have all the slack out, I can get her here, I can side glide her away a little bit. It talks about secondary levers, okay? So it's just saying my primary lever is here and down glide her. If I still feel like there's a little slack and I'm not quite in range, then I can take up the slack a little bit more, especially if I were gonna thrust this, okay, an HVLA grade 5 manipulation. Then I'm gonna probably side glide her a little bit more. I may rotate her a touch to take up the slack and make sure that I'm focusing that attention here, all right? And then if I wanted to do a thrust, I could do just a quick impulse right at end range, okay? But I've cleared them. I would have cleared them. Alar ligament, vertebral artery, transverse ligament, okay? All that stuff would be clear. Of course, I follow this with the courtesy stretch, okay? The stretch. So that's the down glide. You still have capacity for one more? Okay, because, or you want to try those first? Try those first? Try those first, okay?
What was the first technique?
This spine. Gather around where you can see the spine. Okay, I want you to look at the facets because I think it's going to help you understand what you're doing with the down glide, first of all. Okay, so look at the facet orientation. This is really sitting down over top of this, right? So Emery would like to explain to us what a down glide on the right would be useful for.
It is good for side bending to the right,
Mm-hmm.
rotation to the right, and also backward bending.
Excellent, yes. So it would be a useful technique to help improve all three of those motions because in ipsilateral side bending, we're getting a down glide to the right. Ipsilateral rotation, we're getting a down glide to the right. Right? Friat's laws, doesn't matter for inflection or extension, side bending rotation are happening in the same direction. And that's because of the facet orientation, right? And then also backward bending, we're getting a down glide of the facets, okay? So that was the down glide. The next technique we're gonna do is a lateral glide. It's a little different. For the down glide, I had patient's head in my abdomen supporting it. For this one, I'm not gonna have it. I'm gonna let it stay on the pillow. It's still in a slightly flexed physiological neutral position. Now, instead of getting on the articular pillar and going down on that 45-degree angle, okay, to down glide, my line of force is more directly lateral, okay? So I'm still gonna get on the articular pillar, but this time instead of gliding it down, I'm actually gonna push it to the side. Boom. A lateral glide, like a side glide. So it's gonna look more like this than this. Or like this instead of this. Down glide, lateral glide, okay? So can I get a patient, please? Is comfortable, relaxed. I love the bolster, okay, for almost anything I'm doing with patient supine. If you get them relaxed, they're gonna be much more cooperative with whatever you're doing, okay? So again, down glide, I'd have him supported against the pillow, but this is the lateral glide. I'm gonna let him just stay in a physiological neutral position. I may even do this, okay? I don't want him in a lot of flexion, but I just want him relaxed and neutral. Same, it's very similar. This is just repetition of the same sequence. I find occiput, C2, spinous process, get this part of my hand against the articular pillar, and now this time I'm laterally gliding, okay? And then the other side, laterally gliding. Work down a level, laterally gliding, okay? Laterally gliding. Relax. There you go. Okay. Any problem with this, Mason? Is it hurt? Okay. Mason's a big, strong guy, though. I'm telling you, your big, strong guys are kind of the worst. Like, they don't want you to feel like you're having to hold their heavy hits. They will try to hold it for you. I just work my way all the way down. C2, C3, down to the base of the mid-cervical spine. Okay? Comparing left to right. Okay? Now, as you see where that looks different than, relax here, than the down glide. The down glide, he's supported. See how he's going into side bending and rotation. This is down glide. Relax. This is lateral glide. Can you see the all see the difference? Okay, so that's the lateral glide, all right? Okay, and the next ones we're gonna go to are all up glide techniques, and there's several of them. Do you wanna do this one first, or you want me to just start in with the up glides? Or does that help you to do this quickly? Let's do it quickly, and then we'll jump in, we'll do multiple up glide techniques. What is the lateral glide important for? What do we need that for? Okay. And so what we concluded is that a lateral glide is a joint play. So just like distraction of the knee, it's a joint play. It's not necessarily a component motion, but improving lateral glide will help improve essentially all the motions, okay? Up glide, down glide, and all the motions at the cervical spine. All right, can you choose to do the lateral glide for every scenario you get for your practical? Probably not. Pretty sure you're gonna get that follow-up question. What else could you do? What would be more specific? So I wouldn't think that you can just get away with using that, but there is some notes in there in your Olson book about correlation of that to lateral flexion in a Fernandez de las Peñas article. So you can look at that, but it's a joint play. Okay, good question, Kiki. All right, so we're gonna go up slide, up glide. Same thing, up slide, up glide. Okay, so again, to review for this, facet plane, about 45 degrees, right? So we were talking about with the down glide, we were getting on articular pillar and gliding down toward the opposite hip. when we are doing the up glide, we are going to use this part of our finger, and we are going to cup the articular pillar. So I like, again, to start top down. So I will find occiput down to C2 spinous process, come over here to the articular pillar, get this part of my index finger on it here, and then is this motion. So I'm hooking the pillar, and I'm coming up at a 45-degree angle toward my opposite shoulder, okay? So that's the motion. Now for the down glide and for the lateral glide, I usually go right side, left side, right side, left side. For the up glide, I usually just check one side in its entirety and check the other side in its entirety. It just feels a little bit more natural for me to not have to, it's a lot of work to find it, get my hand in position, and it's just a lot of shifting back and forth. I'm more efficient if I do one side at a time. So I will come here, find C2 spinous process, hook the articular pillar, and feel C2, C3, C3, C4, C4, C5, C5, C6, C6, C7, okay, so on and so forth. Then I will work my way to the other side. The other hand is taking more of a supportive role. Coming here, finding articular pillar, the C2, C3, C3 on C4, C4 on C5, C5 on C6, C6 on C7, okay? Maybe C7 on T1. Right? So that's how it looks on the model. Can we get a patient, please? Side bending which way? Okay, so that would be like a contralateral side bend, right? Okay? You're showing it right. Just get your wording right with it, right? Okay? So you said what you showed me was if I side glide to the right, which side up glides? The left. Okay? So if you're doing a left up glide, you would say that it improves contralateral side bending. Okay? And contralateral rotation. Okay? You don't have any neck issues, do you? All right. So again, supine. I'm going to get his head supported. I feel like we need a little bit more, so I'm going to fold the pillow over, relax here, physiological neutral, okay? Again, I'm right hand dominant. My go-to is to start with the right side. You probably are going to find that you have one side that just feels a little more natural to you as well, and that you feel really awkward on the opposite side. That's natural, okay? You just got to practice, practice, practice till it becomes less awkward, okay? C2 spinous process. I'm going to work over here to the articular pillar, cupping it right here with my index finger. Okay, this hand is just going to support and cradle, and I'm coming up. So I am just encouraging up glide. So now I'm going to work down C2, C3, catching the articular pillar, and my force is this. Okay, I'm coming up toward my opposite shoulder. Work down another level, about C4, C5. I'm going to compare. So now this hand takes supporting role. I'm coming to the other side. C2 spinous process, using this part of my finger to cup the articular pillar. And I'm facilitating an up glide and just feeling how much motion happens at each level as I work my way down. Didn't feel anything really substantial that stuck out to me super significantly different on one side or the other. So I'd have probably called him a grade 3 normal, okay, both directions. No crepitus, no aberrant motion, smooth, okay. Just a normal, firm infeel. All right, now, if I did find a restriction and I wanted to manipulate it, okay, let's just say that I found, we're on this side, so you can say that. All right, so let's say that I found that C5, C6 didn't up glide well. So I will come back here, C2, C3, I'll just do it again, right? So I'll work my way down, find that level, C3, C4, C4, C5, C5, C6. Okay, I'm gonna pretend like that's a restricted level. So I've got my hand in position here. Now, I'm going to take him, and I'm going to take up the motion here like this. I'm like, okay, that's restricted. So I can just take him to in range here. I can do some grade 1 oscillations. I can do some grade 2 oscillations, some larger amplitude beginning to mid-range. I can do some grade 3 oscillations, right? Large amplitude, mid to end range, not quite end range, but the latter end of the range. I can go to end range and I can do some little oscillations. But if I wanted to turn this into a thrust manipulation, a grade 5, high velocity, low amplitude thrust, okay, I'm not going to do it to you, but I could take him here and I could get into more of a cradle position here. I could get him I can rotate him down to where I feel like we've got rotation at that segment, okay? Get my hand into a position like so now, where I feel like I need to take up a little more slack so I can side glide him away, okay? I can distract him a little bit more to just really take up the slack at that level. And then from here, in the motion of rotation and up glide, I can do right at the end range just a little impulse, okay? Which is impulse, just a quick. But the key to that being effective is that you've taken up all the slack. Okay? It's sometimes just taking, rotating, or up gliding to that point. If not, there's still a little play. There's still a little play. Here, I'm going to side glide him, take it up. Okay, I may distract and or extend above a little bit till I get to that position, and then it would just be, okay? And then the courtesy stretch, distraction. Right? So, we all good with that? All right, let me show you a couple of these other techniques. These all apply to the up glide. Back to our PowerPoint for a minute, because I want you to at least see this. This may not be your go-to, but I at least want you to see it. Okay, this technique here that says this is specific reach over, lift up, and hold. Some people will call it the grip and rip, okay? I'm not going to grip and rip, okay? But let me show you on this so you understand what I'm doing. Up glide. So again, if I found an area that was restricted, I'm going to lay this across your belly, is that okay? All right. If I found an area that was restricted, now I can come across anteriorly. So let's just say C2, C3, C4, C5, C6. Let's say it was C5, C6. Now, I can come across anteriorly, and I can move his SCM out of the way, and I can actually block the lower level anteriorly, like so. So I'm going to get here, pushes his SCM out of the way, and just put my hand here like this. Now I can take my hand just like I did for the other techniques on the level just above it, come across to the articular pillar, and I can get it like this. This is way too high for me right here, but right now I can get here, I can stabilize and block, and I can get here on that same diagonal, and I can do a stretch like so. So I'm reaching over and I'm lifting. So it's called reach over, lift, up, and hold, okay? So I could do a static stretch, I could do some oscillations, or some people do the grip and rip and they thrust it here, okay? But this is what it looks like on a patient. I just want you to understand what this is, all right? So again, you're going to use wisdom on who you use this technique with, period. Your patient who has a history of trauma, maybe some domestic violence, okay, they probably aren't going to be real appreciative of some hands around their neck. Use wisdom, okay? You good, Mason?
I'm good.
All right. So here's his SCM, right? I can come through, and I've probably already come around, and I have located, so C2, I've located that area where I feel like we have the I don't really feel restriction on Mason, but we're going to go pretend like we feel restriction right here. This is where we're going to treat, okay? I'm going to come here, and now I can push his soft tissue out of the way, and I get down here to where it's firm. You okay right there? Okay. You see how this could look a bit questionable? Okay. If your patient doesn't understand what you're doing, they may be like, what in the world are you doing to me? So taking up the slack. Come down a little bit more. But it actually is a pretty effective technique. This would be a good technique for somebody who does have, maybe they have a fusion. Maybe they're fused C6, C7, but I really feel like they're really restricted C3, C4. So I want to do this technique, but I want to ensure that I'm not just cranking on their fusion site. This would be a good technique because just like the C2, the distraction with C2 stabilization, I can isolate that distraction to the superior segments. This allows me to isolate that motion to one segment a little bit more effectively. Okay, so it's a good tool to have in your toolbox. Needs to be the right patient. You need to have good consent. It's a tool you have. Okay, so that is that technique. Yes.
Technique was it called?
It was called. On your slide, it's slide 17, and the cervical spine non-thrust and thrust manipulation PowerPoint. It says apply specific technique, reach over, lift up, and hold. Alright? Now, we're going to kick. In that presentation as well, you'll see an upslide and prone line, okay, which is essentially a similar technique to the unilateral PA, EIVMT on page 402 for the assessment, and then the mobilization on page 407, 408. Those are very similar techniques, okay? So we're going to get our patient prone now. Okay, so patient prone, pillow under, you can put it under the waist if they need it, under their feet if they need it, but here's what we're going to do. This table allows me to, we still want to keep physiological neutral. When you get them here on a flat plinth, that's going to kind of pull them up into like super neutral or maybe even a little extension. We don't want to be there. So if you have a table that allows you to, are you good with putting your face here? All right. Then see, he's just not quite flexed enough for me here. I can, no, you're good. Or wherever you need to be comfortable. But I can use the table and let it come down just a touch to create the physiological neutral now. It's great. Not every clinic you work in or every table you use in the clinic is going to be like that. So if it's a flat table and you can't do that, lift up here for me. You can create that by putting a pillow under their chest so that now when they come down to the table, pretend like this is the table, right? Rest your head, just rest it in my hand. Okay, then you can create that flexion that way. Okay, but we don't need it here with this table because it works well for us. So I will take this instead and put it here because I want Mason to let go of everything. So I don't want him feeling like he's got to hold his legs. Okay? Roll this down some. Okay? So now we're going to do an up glide technique. We're just going to facilitate, we're going to feel how those facets are up gliding. Lay the spine on your back for a minute. So if I were to be, I'll come around that way. If I were to be on this side, doing an up glide, I can come here again on the articular pillar. I can use a dummy. You can do, I think your book describes two techniques, either putting your thumbs together like this and getting on that articular pillar and pushing up, or using a dummy thumb. I like to use the dummy thumb. I put one thumb here. This is just a dummy thumb. My mobilization thumb, okay, that's applying the force, is my top thumb. And so what I'm going to do is I'm just going to up glide that facet, okay, 45 degrees to the horizontal. I can do this, okay, 45 degrees to the horizontal. I can do that at all those levels of the mid-cervical spine. And I can even do this into the upper thoracic spine. Now you'll notice in the spine that the facet plane changes. So when we get to that upper thoracic spine, which we'll do moving forward, instead of being 45 degrees, it's closer to 30 degrees. Okay? So on a patient, okay, it looks more like this. You can see Mason's already red. He's getting a little histamine response to all this stuff we've been doing back here. Okay, so I can bring him up a little bit. Dummy thumb, okay, mobilization thumb, and I can up glide. Just encouraging some sinking through the soft tissue. Mason has a lot of muscle back here. Okay, so I've got to sink through that and get to the firm articular pillar, and then encourage and up glide. Okay, and it says, I think on your slide it even says a PA, a unilateral PA. So I'm up glide. So on the thrust and non-thrust manipulation technique, it describes it more as an up glide. In the Olson book, it describes it more as more of a PA. Okay, and it's a very similar technique, The force may be slightly different, okay? Encouraging the upglide versus a little bit more of a PA pressure. Still both to improve upglide, okay? Work my way down, sink through the soft tissue. You okay, Mason?
That's fine.
Okay. Of course, we don't want to push through necklace or chain. Move what you need to move, or have the patient remove it. Okay. If I go to the other side, dummy thumb. Sink through, apply the mobilization. Again, first for assessment, but if I found one that was restricted, then I can utilize all those oscillations that we've learned. Okay, I'm not going to thrust in this position. I'm not as likely to be effective doing that, but I could definitely do a grade 1, okay, grade 2, grade 3, okay, or a grade 4. Okay, and the courtesy rub down. All right, so that's the upglide, the unilateral pivot, and the unilateral PA mobilization, and the upglide technique from your slide. Any questions about any of those? All right, let's try those. And the reach over, lift, and hold. Alright, can I get a patient up here on your belly? I'll show you here while I'm waiting for my wonderful patient. Okay, so this is a central PA technique. We don't use this necessarily, it's not necessarily my go-to with when I'm trying to improve somebody's motion, okay? But what it is, often you will see it in the literature for pain provocation. They will do a central PA, 2 thumbs, right on the spinous process. Again, there's no spinous process of C1, so I'm gonna be here C2, and I'm just gonna provide a PA. Central right on the spinous process, and I'm sensing to see if that causes them to withdraw, if it produces any pain. Okay, you will see that is one of the criteria for this clinical prediction rule for cervical manipulation. Okay, so it's kind of important to know what it is, what they're talking about. It's not necessarily, again, my go-to for improving mobility. So can I get a patient up here, please, on their belly, facing the hole? If you're not able to face the hole, we'll use a pillow. Thank you, ma'am. Can I slide this up slightly? Mm-hmm. Okay. All right, so I'm going to come here, occiput, physiological neutral. Here is her C2 spinous process. I'm going to be very gentle. I'm going to come down here. I've got 2 thumbs here, and I'm just going to apply a PA. Okay. Work down a level to the next spinous process. Sink through the soft tissue. Apply a PA. Okay. Work down 1, so that should put me about C4, PA. C5, they get really tight in here once you get down C4, C5, C6, they get really close together. Spinous process, yes. Okay, and I could go on down the spine with the central PA. Okay, but you will probably, again, most likely see that with pain provocation. But that is the central PA. Okay?